All right, love you.
What is this?
Okay. Good evening, everybody, and welcome to the sixth annual Virtual Diabetes Symposium. I'm Sarah Bloom, the Executive Director of the Delaware Diabetes Coalition. And who are you?
Mm,
This is Joey. If you've joined us before, you know my daughter usually likes to make an appearance, and so this is it tonight. Thank you for joining us. I also want to thank Kimmy Moore, our president. She is a RD, as well as Amy Hastings, who is a fellow school nurse in the Appoquinimink School District, and she gathered all of these lovely speakers for us over the next two nights. So, just a little bit about who we are. We're a statewide nonprofit that is comprised of a network of healthcare organizations working together to improve the lives of Delawareans that are living with diabetes. And we do that through awareness, prevention, identification, and dissemination of services and advocacy. We do two big events a year, this one being one, and the other one is our expo in November. That is more geared toward type 2 patients. It's in person. It's a big resource fair and education opportunity for those patients. I added this year, just I want everybody to understand who else is on the call tonight. We have over 300, um, over 300 registered, which is a record for us. And coming from 65 different school districts, 28 are in different healthcare organizations, and 24 other. And the geography, we have 13 states represented. Of course, Delaware is the largest representation. This is geared toward Delaware school nurses, but we are happy to be able to offer CEs to other industries in other states. And so, and everyone here tonight is either an RN, registered dietitian, a CDCES, a pharmacist, or a pharmacy tech for the most part. I want to let you know that this all started 6 years ago because I needed help getting the word out about our college scholarship. We offer $1,000 to a Delaware resident, whether they're in college or a high school senior, if they have type 1 or type 2. And I was struggling to get applicants. We now receive quite a few, which is a great thing, but I definitely want to make everyone aware. The deadline this year is April 30th of 2026, and they can get $1,000 to their institution. Please keep spreading the word. Another program that we've started in the last few years is a partnership with the Lions Club of Delaware and the Department of Education. You can get free three-level diabetes training for all Delaware schools, public, private, parochial. It is open to everyone. And if you are a school nurse, you can get 6 CEs for the courses that are available online. It is self-paced. There is a pre-test and a post-test. And as of December 31st of 2025, we've had over 550 enrollments over 2 years. 71% of Delaware school nurses are participating so far. And of all the schools in the state, we have 209. So we are still working to get to that 100% mark. Sorry. Um, and actually, if you look at this chart, you can see how we're tracking for year two. We just got the January numbers today. And so we're a little behind over last year, but note that last year we had several more months leading up to January of 2025. So if you have not taken your course yet this year, please do enroll and take that opportunity to get 6 free CEs. If you took it last year, you can, Joey. If you took it last year, you can take it again this year, so you can get a total of 12 over the course of 2 years. So tonight, to get your CEs, you have to complete the course by watching this webinar, 120-minute webinar between tonight and tomorrow night, so 60 minutes each, or no, 120 minutes tonight and 120 tomorrow. And you have to complete the eval that I'll put in the chat at the end by March 1st. Please make sure that you use the same email address that you use to register for this webinar when you fill out the survey. You will also have to self-attest of how many hours you believe that you deserve. But I will check that against the Zoom record. So you can get two contact hours in the following organizations. And if you care to see any of the speaker disclosures, they are all on our website. Tonight's learning outcome is upon completion of this activity, Learners will demonstrate increased knowledge and application of current evidence-based strategy for diabetes prevention, management, and technology integration across the lifespan. Learners will be able to identify at least 3 emerging diabetes technologies, apply updated clinical and psychosocial care strategies to real-world scenarios, and describe at least 2 actionable approaches to improve person-centered equitable diabetes care within interdisciplinary practice settings. Sorry. And tonight's agenda, then you need to go downstairs.
Yes.
Wait, sorry. Tonight's agenda, starting at 6:30. Hang on one second. Go with Daddy. Um, please take her away. Tonight's agenda starting here with Crystal Woodard from the American Diabetes Association, keeping students with diabetes safe at school. And if you do have questions, please use the Q&A. We will ask them at the end. And just a real quick synopsis of Crystal. We are excited to welcome Crystal Woodard, Vice President of Legal Advocacy at the American Diabetes Association. Crystal leads the ADA's nationally recognized Safe at School campaign and is considered a leading authority on the rights of students with diabetes. She's a longtime advocate, a parent of a child with type 1 diabetes, and played a key role in passing the nation's first Safe at School law in Virginia. Crystal has helped shape many of the ADA's core school and legal resources and continues to advise state and national diabetes initiatives focused on safe, equitable care in schools. And so without further ado, please welcome Crystal. And I will stop sharing. Oops, I always hit the wrong button. There we go.
Okay. Thank you so much, Sarah and Joey and Amy. Delaware Diabetes Coalition, thank you for giving the American Diabetes Association this opportunity to talk to school nurses about the provision of diabetes care in the school setting and the legal protections for students with diabetes. And I just want to take a quick opportunity to thank you all. I know that school nursing is very rewarding. You all are so committed, but I know it's not easy. You have a lot of competing priorities. So just appreciate you taking the time to attend this webinar. The ADA is here to support you. We have resources. Love to hear from you on what resources you don't have that you'd like to have. And the one other thing you might find of interest, Sarah told you that I have a daughter with type 1 diabetes, my daughter Devin, and she was diagnosed when she was a year old. She's about to turn 36, and she's doing very well. And what I wanted to share with you is that it's because of her positive experiences with her own school nurses that she decided to become a nurse. So she has been an ICU critical care nurse in suburban Washington, D.C., I guess for about 14 years now. So we always credit her school nurses with that career decision, which has been very rewarding for her. I'm Crystal Woodard. I'm the Vice President of Legal Advocacy, and I have led the association's Safe at School effort for almost 3 decades. So I've been around a long time, seen a lot of changes, as you all have, with technology and diabetes treatment therapies. And I know the challenges firsthand on staying on top of all the new developments. We at ADA attempt to ensure that all of our information is accurate. This is
Hey,
just general.
Crystal. I'm sorry.
Yes.
Do you mind just hitting your the present slide just so it gets bigger for the group?
I'm sorry. I thought I had done that. My apologies. Ah, here we go. How's that?
It did not change for me.
Huh. All right. How about if I stop and start again?
Okay.
I'll just stop sharing. And then
Okay. You're back, but we don't see your screen now at all.
Let's see.
Okay, we see your screen.
How about now?
There it is. Perfect.
Okay, sorry
Thank
about that. I
No
don't know what
problem.
happened. My
Thank you.
apologies. Absolutely. The association, we attempt to ensure that all information is accurate. This is general information. It's not a substitute for legal or medical expert advice. So if you have those medical and legal questions, please consult with a medical or legal expert. Again, I'm Crystal Woodard. I'm Vice President of Legal Advocacy, and I also lead the Safe at School effort at the American Diabetes Association. At the American Diabetes Association, we have a trifold mission, obviously to cure diabetes and to support that research to prevent diabetes, and also to improve the lives of all of those folks impacted by diabetes. And that's the patient with diabetes, it's the families of patients with diabetes, it's, friends, community members. But I'm going to really focus on improving the lives of those who are impacted with diabetes, in particular, youth and adolescents with diabetes, and those students with diabetes. So today we're going to focus on advocacy and the association's Safe at School initiative. First, let me just give you a few statistics about diabetes. According to the 2023 Centers for Disease Control estimates, about 364,000 Americans under the age of 20 have diabetes. Right now, there are roughly about 314,000 youth with type 1 and the remaining with type 2, and there are about 40 million Americans with diabetes. And diabetes is the seventh leading cause of death in the United States in 2023, just to put it in perspective a little bit. So our Save a School campaign at the ADA, which was founded about 3 decades ago, is based on 3 guiding principles. The first is that all school staff members need to have some basic knowledge about diabetes and know who to contact for help. And by basic knowledge, I mean, what is diabetes? What are the symptoms? What's the basic treatment? And most importantly, what do diabetes emergencies look like? And who to contact for help, especially if a student is experiencing life-threatening hypoglycemia. The second principle that our campaign is built around is the school nurse as the primary provider of diabetes care. But it is the ADA's belief that other school personnel must be trained to perform diabetes care tasks when a school nurse is not present. Now, I know in Delaware, you're very fortunate in that you have a school nurse in every school, but most states do not have that luxury. And it is critically important that there always be available a school nurse or another trained non-clinical school staff member who can provide that care in accordance with the student's prescriber's orders or diabetes medical management plan. And also, that's what's required under federal law in order for the student to be able to safely access the school setting. There must always be someone who has been trained to take care of that individual student's diabetes. And third, for students who are capable of self-management, they should be permitted to self-management and provide self-care anywhere, anytime, and be able to carry their supplies and medications and snacks on their person wherever they happen to be within the school setting, whether that's a school day, during an assembly, lunchtime, at a sports event, school dance, after school activities. they should be able to self-manage if they're capable and carry their supplies and medication. And these principles are supported by all of these organizations. I'm not going to read them. You can see them here. So we know that it definitely takes a village to support a student with diabetes in the school setting. So these are the key stakeholders. Our work and a lot of the resources, all the resources ADA develops, focus upon one or more of these audiences because these are the stakeholders around the student with diabetes. And these are the stakeholders who are knowledgeable and empowered to make sure that student with diabetes receives appropriate care and is able to safely access all that schools have to offer. So we've got obviously the families, the students' diabetes healthcare provider, the school nurse, school administrators, local school policymakers, school board, school directors, teachers, guidance counselors, food service managers, bus drivers, and other school personnel. Then, of course, state level policymakers who determine state law. And as I'll talk about in just a little bit, the legal protections for students with diabetes do stem from federal law, but also some states have laws that are relevant to who may provide diabetes care in the school setting to these students. So all these stakeholders are very important. So what do we know about diabetes? And as school nurses taking care of students with diabetes, you're all too familiar um, with these premises, but diabetes care is 24/7. Unfortunately, when parents put their child on the school bus in the morning, their student's child's diabetes cannot take a break. We can't put it on hold. One of our goals is to ensure a smooth transition from home to school, with the understanding that sometimes the care that's delivered at school may be a little bit different from the care that's delivered at home. And that's really a conversation that the school nurses need to have with the parents and the family. A student must have access to equipment, medication, and assistance because diabetes is 24/7. All of these pieces of equipment, pump supplies, glucose tabs, juice boxes, anything and everything the student needs to take care of his or her diabetes must be accessible. Also, fluctuating out of range blood glucose levels may adversely impact learning and behavior. So if a student's blood glucose level is low or student's blood glucose level is high, that could impact cognition and their ability to engage academically and to perform well on tests and on assignments. So that's really a goal, right? To keep those blood glucose levels within the student's individualized target range. And we also know that written plans are essential. So there are goals for safety and inclusion for students with diabetes. Schools must provide a medically safe environment for students with diabetes. And basically that means that there must be someone on site who's trained to provide the level of care needed by that student. And it might be that your student is newly diagnosed or is young, maybe a kindergartner, or first or second grader. So you know that the level of care that needs to be provided to that student is going to be very different from the high school student, whose skill set should be very competent by that point in time. But every child's different. So we want to make sure that there is the appropriate level of assistance available to that student. Students with diabetes must have access to the same educational opportunities and school-related activities as their peers. So, as an example, if a student with diabetes is on the varsity football team, there must be a trained coach, licensed healthcare professional, um, trained school employee. Maybe many times it's the coach, many times it's the athletic trainer, but there needs to be someone with that student who can, at a minimum, recognize hypoglycemia, give glucagon, or know who to contact in the event that help is needed. School nurses and administrators should work with the parent, guardian, and the student to reasonably support daily diabetes management activities. So we want everybody to work together. Again, it takes a village. So unfortunately, for some schools, I wouldn't say most, but some schools, there are some schools where students with diabetes do face discrimination. And that's where our Safe at School program really comes in, because what we try to do is to identify those problems, create resources, and offer strategies for resolution of those discrimination problems. If kids don't get the care they need at school, then they can't safely access that school environment. And that constitutes discrimination under federal law, and that's illegal. So what does discrimination in the school setting look like? It might be discrimination if families are required to come to school to give insulin or provide other diabetes care. Again, there should be someone on campus or available at a school activity who has been trained to provide the care that has been identified in the student's prescriber's orders or diabetes medical management plan. Families cannot be required to come to school to provide that care. If they want to come to school and provide that care, that's another conversation, but they cannot be required to come to school to provide that care. If schools don't have a school nurse, or they do not have trained non-clinical school staff members available at times, then that student cannot safely access that school environment. So we need to make sure, again, and I know I sound like an Excedrin headache, but this is still one of the most frequent complaints we still receive, is that schools do not have a school nurse or they don't have trained personnel. So the student cannot safely access the school setting. So that is critically important. Also, some children are told they can't go on field trips or participate in other activities unless a parent is present. When the kids are younger, I know with my own kids and they went on field trips, I always went along. They want to be there, but there's comes a point when kids grow up and they don't want mom and dad tagging along anymore, or perhaps mom or dad are working and they're just not able to accompany their child on the field trip. So it is a legal responsibility of the school to provide, again, a school nurse or a trained non-clinical staff member to provide that needed care. Student athletes not being able to participate in school sports because the school refuses to provide trained coaches or other staff, or what we've been hearing about lately. It's really kind of shocking. I would say in the last year, one of the common occurring challenges we're hearing about is athletes who are being sidelined and being told by their coaches that they can't play because of their diabetes. So that's really sad, and that's illegal. So we're hearing more about that these days. I'm not really sure why, but that seems to be on the increase. Also, students who are denied smartphone or cell phone smart device access to manage their diabetes, that would constitute discrimination. And I know that Delaware just passed a cell phone restriction law. I think it was just passed a couple of days ago, as a matter of fact, and I'll talk about that in a couple minutes. Students who are denied the opportunity to take an exam at an alternate time if they have low or high blood glucose levels. So, we want kids to optimally perform. We want them to feel good. If blood glucose levels are out of target range, they're just not going to perform well. So we want there to be a mechanism put in place in that 504 plan that says what's going to happen if the child is high or low in terms of making up missed assignments and being allowed to take an exam or test at another time. So there are federal and state laws that protect students with diabetes and place legal obligations upon schools and other entities to provide appropriate diabetes care. And these main laws are the Americans with Disabilities Act, or ADA, Section 504 of the Rehabilitation Act of 1973, or Section 504, the Individuals with Disabilities in Education Act, or IDEA or IDEA. There are also state laws, regulations, and guidelines that all impact who may deliver care, medical care, diabetes care, medication administration in the school setting. So you'll want to be familiar with your state's laws. With all that said, these laws do help to level the playing field for students with diabetes and ensure a safe and fair school environment for our students. And you can find out more information about federal laws and your state's laws. I know these are, you all are mostly Delaware school nurses, but I see that there were nurses from other states. So if you want to become more familiar with your state law, you can go to this URL on the association's webpage, and there's a drop-down box, and you can just click on your state and learn about your state's laws that are relevant to the provision of diabetes care in the school setting. So I just want to go through, just provide an overview of these main federal laws. The first being the Americans with Disabilities Act. The obligated entities under Title I, the ADA applies to state and local government entities. So that means public schools and other institutions who receive government funding. Title III of the ADA applies to places of public accommodation. And when we're talking about kids, that means that the ADA places legal obligations upon camps, recreation programs, daycare providers to meet the requirements of the Americans with Disabilities Act and to not discriminate against people with disabilities. And diabetes is a disability under the Americans with Disabilities Act in Section 504. So just know that. Diabetes is a physical impairment that adversely impacts a major life activity. What that means in a nutshell is because diabetes interferes with proper endocrine system functioning. Endocrine system is a major life activity. Diabetes is a disability because that's what diabetes is. It is, the endocrine system is not functioning properly. So that's why diabetes is a disability. Religious entities are exempt. They don't have any obligations to provide diabetes care under the Americans with Disabilities Act. However, if religious entities, religious schools receive government funding, they do have obligations to meet the needs of students with disabilities under Section 504. So what does the ADA require? Well, it prohibits discrimination on the basis of disability. I just gave you the definition of disability. And again, diabetes is a physical impairment that substantially limits a number of major life activities: endocrine function, eating, walking, talking, performing manual tasks. And that's not an exhaustive list. Those are just the major life activities that we normally talk about. The ADA also requires those obligated entities to make reasonable modifications in policies, practices, or procedures to ensure that that student with a disability like diabetes does have meaningful and equal access to all programs, services, and activities. And for some reason, I have lost my Section 504 slide. My apologies. So I will just tell you that Section 504 is another federal law that prohibits discrimination on the basis of disabilities. The entities that have legal obligations under Section 504 are public schools and also private schools receiving government funding. Those schools would have legal obligations to meet the needs of students with diabetes. And normally what would happen would be there would be a development of a Section 504 plan, which we will talk about in just a little bit. And then with the Individuals in Education Disability Act, or IDEA, for students to be eligible for services under IDEA, it would need to be demonstrated that the diabetes or another disability adversely impacted academic performance or progression. And in that instance, the student would be eligible for an individualized education program or known as an IEP. So in addition to federal laws, there are state and local laws. The state laws, your Nurse Practice Acts in particular, determine which staff are permitted to provide care. For a student with diabetes, that would be insulin and glucagon administration, blood glucose monitoring, nutrition monitoring, all balanced out with physical activity. Also, many state laws do contain a provision permitting self-management for capable students. Many state laws prohibit diabetes schools, and what I mean by that is that students with diabetes cannot be segregated to one classroom where all the sick kids are, or where all the kids with diabetes are, or to a special school that has a full-time school nurse. The students with diabetes must be integrated in the classroom with the other students. So, in addition to federal law protections, a lot of states do have a provision in their laws prohibiting this kind of segregation. The last couple years, we have seen an increase in states, legislatures who are passing undesignated glucagon laws. These laws enable schools to obtain a prescription for stock glucagon so that they can maintain glucagon at school in the event that a student has forgotten their glucagon, maybe the glucagon kit has expired. So there are a number of states who have these laws now. And then the other recent trend is cell phone restrictions. There are many states, including your own, whose state legislatures have passed laws that restrict student access to cell phones during the school day. I will say that ADA has been working with the state legislators to ensure that there are exemptions in these laws for students with medical conditions like diabetes who require to have access to their cell phone in order to manage their diabetes. So what are the laws in Delaware? In Delaware, we know school nurses administer medications such as insulin. We know that unlicensed staff may be permitted to provide emergency assistance, such as glucagon administration to treat severe hypoglycemia. We have not identified any Delaware state laws presenting barriers to self-management. And I just have to say, at ADA, we have a service we provide to folks with diabetes and their families. We have a lot of parents who call us on our 1-800 number to get help because their schools aren't administering care appropriately for one reason or another. I have to say, we really don't hear from Delaware parents. So that's to your credit. I mean, you guys are doing really a great job of taking care of kids with diabetes. So not hearing very many problems there. So you're doing a great job. As I mentioned earlier, your state in Delaware, the cell phone restriction bill passed, Senate Bill 106 passed on January 29th, and it awaits the signature of Governor Meyer. So stay tuned for that. And that cell phone restriction law does contain a medical exemption. We are advising parents to also write a provision in their child's 504 or IEP that explicitly allows the student to access their cell phone. So that is our advice for parents. Even, with those states with these restrictions, these restrictive statutes that have the exemptions, we still are advising the parents to write this provision in their child's 504. And you do not have in Delaware an undesignated glucagon statute. So maybe that's something to think about. Written plans for diabetes management for school are the foundation of diabetes management at school. We have the DMNP or Diabetes Medical Management Plan. These are the prescriber's orders. ADA has a very comprehensive DMNP. I'll talk about that again in a minute. A 504 plan, an individualized education program, depending on which law the student falls under for eligibility. Nurses normally have an individualized healthcare plan, which is basically the school nurse roadmap for how care is delivered in the school setting, an emergency action plan, and a quick reference plan. If you're familiar with our school guide, you know that we have sample quick reference plans in the back of that guide on how to recognize and treat hypo and hyperglycemia. So first, the Section 504 plan. What is it? It's a written document where the parent, guardian, and the school agree on the services and modifications that the student needs. It's not a one-size-fits-all plan. Each child with diabetes has individual needs, and we've recently done some updates and improvements to our template plan. We have incorporated more diabetes technology. We've incorporated cell phone access. So please check out this plan. Again, it's not a one-size-fits-all. There's some provisions in this plan that won't apply to every student, and then for some students, every provision will be helpful to that student. But just know that ADA has developed this template plan that's available for free on our website, along with all of our other resources. So what are the benefits of a student having a 504 plan or IEP? It helps to clarify the roles, responsibilities, and expectations for all the stakeholders, the school, the student, the parent, guardian, teachers, school nurses, administrators, bus drivers. It validates the health condition for the student and what the student needs to optimally function during school-related activities. It validates it, it puts it in writing. I always say if it wasn't written, it wasn't said. If it's not written down, it didn't happen. So it's just so important to put it in writing. And I should say that 504 plans under the regs are not required, but they're recommended. So a school, even if a child doesn't have a 504 plan, and the association strongly recommends that every student with diabetes have a 504 plan or IEP or some other kind of written accommodations plan. But even without a plan, the school still has the student still has rights and the school still has legal obligations to provide care for that student. Also, a 504 plan or an IEP uses a formal legal process for determining how the student's needs will be met and also redress if the needs aren't met. So, what happens if things aren't going well? And having a 504 plan or an IEP really makes that a little bit clearer. And also these written plans provide the student and the parent guardian with the comfort in knowing the student will be safe and treated fairly. Obviously, it's important for the school and the family to work together to develop, again, an individualized plan. What works for one student with diabetes may not work for another student. And these are just some examples of accommodations and services you'd find in a 504 plan of a student with diabetes. Also, you would find these in an IEP for a student with diabetes. Just some examples there. And there are many more. Navigating the 504 process, you, the school nurse, you are a critical member of the 504 team. And what happens is the parent usually contacts the school's 504 coordinator to initiate the process. Many times that coordinator is the school principal, other administrator, or a guidance counselor. Also, the school may initiate the process if they suspect a student needs special education or related services. So maybe the parent has not initiated the process for their child, but the school reaches out to the parent and says, hey, we think your child would benefit from having a 504 plan. Let's get this process started. An evaluation for eligibility under 504 IDEA will be conducted by school staff knowledgeable about the child, and including, of course, the parent guardian. And once an eligibility determination has been made, the 504 IEP team will convene to develop a written plan. And usually, that could be one sit down, or it could be a process because sometimes there's some negotiation involved, and sometimes things are not agreed upon, and there is some give and take. So it may take a little while to develop that 504 and IEP. And we advise that the 504 and the IEP be developed before the school year gets underway, or as close to possible to the beginning of the school year, or when that child with diabetes is diagnosed. Ideally before the child returns to school, but that's not always possible, and that's okay. This is the association's diabetes medical management plan. We have had a DMMP for decades. This is the most recent version that was updated last year. There's a new task management section. The orders are clearer for hypo and hyperglycemia. It's a more concise format. There's a list of everything it covers. It's free. You can download it. What I also want to say about this is last week, we posted a survey for school nurses and pediatric diabetes healthcare providers to obtain feedback on our 2025 plan. So you can go to this URL or scan the QR code. And please take a look at the survey, give us feedback. We did a survey a couple years ago. ADA, we extensively reviewed it, and we took everyone's feedback seriously and to heart, and we made all kinds of changes to improve the 2025 DMMP. I suspect what we'll do this year is close out the survey probably probably not in time for the next school year. So I'm thinking it'll probably run through June, and then we'll review that survey feedback and start working on the new form for the 2028 school year. This is what the first, just to give you an example, this is section 1. This is the parent section. It's important information for the school nurse to plan daily care needs and necessary interventions. This is what it looks like. Section 2, what supplies the student or the parent needs to provide for the student. This is all in that first page. This is a very important section, and this is one I can tell you that we struggle with, and I'm sure it's probably going to be a frequently cited topic in terms of feedback on this survey. But Section 3 addresses the student's level of ability to self-manage and how much supervision is needed in the school setting. So this is something that we're still tweaking, but that's very, very important. And then, there are sections 4 through 10 that cover all the basics: insulin, the calculations, mealtime insulin, dose. We have a dosing table, low glucose management, high glucose management. And of course, in the glucose monitoring section, we do address CGM. So you want to take a look at that. So how to get the DMMP review and implementation process underway. Usually there is a meeting between the school nurse and the parent before the first day of school. Ideally, we know you all are really busy those weeks leading up to the first day of school. And so ideally before the first day, but as close to the beginning of the school year as possible, you should meet the school nurse, health assistant, if applicable. Backup school staff are going to be trained, and potentially they should attend the meeting. And what happens at this meeting, you'll review the diabetes medical management plan and child-specific information. Discuss, how diabetes is going to be managed for that student during the school day. And then that ongoing, all-important plan for communication and staff training. And speaking of staff training, the American Diabetes Association has a wealth of free training resources and information. And what you're looking at here is what I call the School Diabetes Management Bible. It's ADA's Helping the Student with Diabetes Succeed, a guide for school personnel. Our last edition was published in 2022. And this year we will be updating select sections of the school guide. I'm thinking probably the sections on insulin, glucagon, and CGM will probably come under review for updating this year, but provides information on how to train staff. It covers all the diabetes basics. It covers the roles and responsibilities of various staff members, training, emergency plans, the DMMP, and just in all of these aspects of diabetes care. In that school guide, you will see that there are 3 levels of training. These levels of training are also cited in the association's school position statement published in our Diabetes Care Journal. Level 1 is that all staff must have a basic understanding of diabetes, know how to recognize emergencies, and know who and how to contact a trained person in the event of an emergency to get help. Level 2, that's the classroom and daily care staff. They need to have a little bit more knowledge about diabetes. And then level 3 is that training that's done by a school nurse or diabetes specialist on routine and emergency care. For example, insulin administration, blood glucose checks. And these trained folks are the ones who help with the diabetes care task when a school nurse is not available. These are, again, we have a wealth of resources at ADA. They're very comprehensive. They are expertly developed by our Safe at School Working Group. Our Safe at School Working Group is our advisory panel of the most highly revered and respected pediatric diabetes healthcare professionals from across the country. And these folks really work hard. They're all volunteers and they work hard to put together our resources. There's just some other examples. We have training modules, PowerPoint training modules with notes that can be used by a school nurse or diabetes specialists to train school personnel. We have case studies which highlight real life scenarios and problems that school nurses frequently encounter. And we have just a ton of virtual workshops on our website that are all free. Also on our website, if you go to our training page, there's a link to our Diabetes Institute of Learning where you will find, I believe it's 6 modules. And they're 1-hour modules, and we offer 1 hour of CEU for each module completed. So you might want to check that out. We want to make sure that we're prepared for emergency lockdowns and other emergency situations. We have some guidance on that on our website, but we want to make sure we're prepared to address hypoglycemia, hyperglycemia, know when to call 911, and what are those communication strategies during the emergency lockdown situations. Special considerations, field trips and extracurricular activities, just some things to think about. Who's running the activity? When is it happening? Who is going to provide that care? What food and snacks are available? Will the student need insulin? Especially in Delaware, that's going to be an important consideration for whether or not you need to send a school nurse on that field trip or have the school nurse attend that extracurricular activity. How old is the student? What is their level of independence? Can they self-manage their diabetes? Can they do their own boluses? And then, what kinds of activities? Is it going to be an active field trip, or is it going to be more of a sit down, going to the theater or doing arts and crafts? So those are all considerations. And the school nurse's role is to support diabetes care through consulting, hands-on assistance, supply access, staff training, and communication. We want to make sure the staff on that field trip are all prepared and that the necessary supplies are taken along. Work together with staff to plan for after-school snacks, easy access to fast-acting carbs for treat lows, and glucagon. And there are also special considerations for transportation. You may, in your plan, want to check glucose levels before a bus ride. You may want to have the child sit near the driver for visibility. Certainly we want to include bus considerations in that child's 504 or IEP. And even recommending a bus aid if possible and if necessary. There's also training for bus drivers that have to take place, when to call 911 or EMS. In some states, bus drivers are trained to use glucagon. So we want to make sure that bus driver is prepared and knows where to find the glucagon. Hyperglycemia is not so urgent for short trips. So we want to provide simple instructions and emergency information to all bus driving staff. So we know CGM monitoring is a big topic. There are considerations. School nurses and parents should get together, have a discussion, discuss remote monitoring. ADA has some excellent guidance on remote monitoring and CGM use in the school setting. There are parent considerations. We advise you all to meet with the parent again before school starts, discuss the CGM plan, who's going to monitor, who's going to respond to the alarms, the device's alarms, come up with a communication plan, ensure device access during exams, request accommodations, keep backup supplies, If you are remote monitoring, you should not be using your personal device. The school or the parent should provide the device. Ensure Wi-Fi access for the device. And one device can monitor a number of students. Define the monitoring roles and alarm response in the 504, the IEP. And remote monitoring adds a layer of support. It doesn't replace DMMP protocols to train staff to recognize hypoglycemia. Again, we have a wealth of free resources online. You can find them at diabetes.org/safe at school. Other key resources, we have information on all the state's cell phone restriction laws. We just developed an undesignated glucagon toolkit for those states having undesignated glucagon statutes. Again, we've updated the DMMP, and there is this live survey online that we'd love for you to go and take. We love your feedback. We have an updated 504 plan. We have our brown bag school nurse webinars we did last year. All those recordings are online. You can take a look at those. Those are great. Those were half-hour webinars, 20 minutes presentation and 10 minutes Q&A on a variety of topics. And they were very well received. And as I mentioned earlier, we have CGM guidance for schools that we will probably also be updating in the first quarter because things change so quickly. So key takeaways: individualized care and plans should be in place for each student. The school nurse and/or trained non-clinical staff should be available at all times. Federal and state laws apply to children with diabetes so that they can have access to care and be safe at school and make sure they're protected from discrimination. The school nurse is well positioned, actually best positioned, to support and advocate on behalf of the student. And please do check out our resources. Toward the end of last year, we created a school nurse network. I've got the URL here and a QR code. Basically, what we do is we send updates every other month to school nurses, just talking about what we're working on, what new resources are available. We don't share this list. You're not going to get a ton of emails from us. It really is a network so that we can let you know what's going on and when we're going to have trainings and when new resources are available. So we hope that you'll join that school nurse network. I think you'll find it very useful. And then for more information, our Safe at School homepage is diabetes.org/safe at school. Our direct link to all of those great training resources is diabetes.org/SAS training. Contact us anytime. Would love your feedback. Here's our phone number. Here's our mailbox. We check these things. We respond. We would love to hear from you. Again, thank you for your time. Thank you, Delaware Diabetes Coalition, for having ADA. I hope you all have found this information helpful, useful. I'm happy to take some questions.
Yeah, awesome. Thank you so much, Crystal. So we do have a few questions, so I'll read them off to you. First, what about schools that are private schools and not required to have a school nurse at all times? How do parents go about handling that?
Well, if it depends on where the school is. Let's say if it's in Delaware, and in Delaware, the law says only school nurse can give medication. So if it's a private school receiving federal or government funding, then that school has a legal obligation under 504 to provide that care. And in your state, it says only a school nurse can provide that care. So I think that you could justifiably advocate for a school nurse in that private school. Now, other states, by the way, there are 35 states that allow trained unlicensed school staff to give insulin and glucagon. So 35 states. So that is the case in most states. So for those other states, a case for support could be made that the private school would need to train an unlicensed staff member. And, check those competencies and skill levels. You're not going to just train somebody and say, here, done, go take care of the student. I mean, this is serious stuff, and we've got to
Absolutely.
always make sure that folks are receiving proper training and that they can competently complete that skill set.
Right. Thank you. Should school nurses be responsible for changing expired CGMs and insulin pumps?
That is a great question. And that is a hot button issue. And again, that is going to differ in every state. Um, the association at this time does not have an official position on that. I'm hoping that we will. I will share with you that there is one state now that has an active bill that would, well, this particular state, I'll just tell you, it's Virginia. And in Virginia, there is a state law that allows, doesn't require, but it allows a school nurse who is willing and trained to do insertions, site changes and insertions. I'm not aware of any other state who has this requirement. I don't have an easy answer for that. Like I said, it's a hot button issue. I think we're going to have to wait and see what happens. In Virginia right now in the legislature, um, there is a bill that, if passed, would allow trained non-clinical staff to do these insertions and site changes. So I think we're going to see a lot more of that.
Gotcha.
Yeah, but the important thing, let me just say, in those providers' orders, in that DMNP, there's always a backup plan, right? Backup plan is, syringe and pen and vial, insulin, and good old-fashioned finger stick blood glucose monitoring. So there should always be a backup plan. And just stay tuned for the insertions. We're working on a position at AEA. And when I say we're working on it, I don't mean just policy people. I mean pediatric diabetes healthcare professionals and school nurses. We have school nurses on our advisory board too. So we're going to cover all the bases. But I'd love, and I'd love to have anybody wants to contact me and talk about it. I'd love to hear your perspectives. This is very important.
Yeah. In a similar vein, are school nurses required to do high-low testing monthly?
I'm not sure what that means. Does that mean on their meter, the kids' meters? I'm not sure.
Okay.
I'm not sure what that means, to be honest.
Justine, if you can clarify your question, I'll ask it again.
Yeah.
Next question. What is
So
response?
quality control on meters.
Oh,
That's something that, I guess, if you want to do it, you could do it. You have the solution, you could do it, but it's
it's not
something
required.
I would think that would be something a parent would come in and do. Or, I mean, is the meter living in the clinic? I mean, if the meter lives in the clinic, then, maybe I don't think it'd be unreasonable for a school nurse to do that. But if the meter is, traveling between home and school, then certainly that's something that should be done at home.
Yeah. Okay. So what is the response when school personnel, I assume like administration, say they want legal protection on assisting and or want extra pay for extra work? So maybe not. Maybe the school nurse saying that they want legal protection or maybe like a teacher. I'm not really quite sure how
I'm
this.
not sure what that means. If it's a liability question, that's what it sounds like. I mean, I would talk to your school district attorney. That's a legal question. And
Okay.
just know too that state laws have immunity provisions. All state laws have, and your Nurse Practice Act has an immunity provision, even for, when you're doing training. There's protection there, usually I don't know specifically what Delaware state law says, but most of the state laws do have that liability protection for school nurses and trained personnel.
Okay. Should you tell a parent if staff is uncooperative? Should a nurse tell a parent?
And I'm not sure what, uncooperative in what way, but I mean, if there are issues, however, you usually resolve issues with staff. Uh, would be, I think, the first step to
Yeah,
talk to the
with
staff member. I don't know how,
HR.
yeah, yeah. And
Okay.
then, if it's an issue with the child, then certainly, you'd want to bring the parent into that conversation.
Is there a timeline or an estimate on when, if Delaware will allow undesignated glucagon?
I have not heard a peep about undesignated glucagon in Delaware.
Okay.
But I'll tell you how this started. It started in, oh my goodness, is it Illinois, Ohio? One of those two states. A school nurse had a student, their student's glucagon kit, they needed it, severe hypo. Glucagon kit had expired, so the nurse grabbed someone else's glucagon kit, right?
Oh,
Administered to the student. Could have gotten into some trouble, right? Um, Instead, she went to her state legislator, told him what happened, and said, hey, we need a law that enables schools to have stock glucagon. And that's how
right.
it started. It started with the school nurse.
Hmm.
So, you
There
know
you go.
what?
There's your inspiration, everybody.
Yeah, I mean, and seriously, I'll put my email in the chat. I'll do that after, well, I'll do that now so I don't forget to do it. But I'd love to hear from you if you have any ideas about resources, if you're thinking that a undesignated glucagon law might be beneficial, contact me.
Cool. Could you speak to checking glucoses before taking the driver's ed car out?
I'm not a healthcare professional. I really can't. But I will say, as a parent of a child with diabetes, this is just from a parent perspective, not healthcare, not ADA's perspective. I think it's a good idea.
Yeah.
Yeah.
And there's no law that says that has to happen, obviously.
I'm not aware of any laws. Now, on our website, we do have, there's a page devoted to driving laws. So you could look there and see if there's
Mhm.
anything.
Okay.
Mhm.
What is the law for a nurse at after-school activities such as drama, plays, sports clubs? I don't think that under contract a nurse can be made to work outside of work hours.
Well, I don't know about, that in terms of the nurse's contract. I can tell you that school-sponsored activities all fall under those federal laws I spoke about, and it is the school's obligation to provide diabetes care during those extracurricular activities. So I can't speak to school nurse contracts, but it is the school's obligation to provide care during those times. Field trips, chess club, varsity football, cheerleading, drama club, anything school related. There needs to be someone there who can provide care to the student.
Okay. So in Pennsylvania, the school nurse is not a requirement in, I guess, in every school. So what if no one wants to take on that responsibility?
Then it would, in other states, the way it's handled is the administrators take on that responsibility. And I will tell you, I've been doing this a long time, and this is a first time for everything, but I am not aware of any school districts who have had problems recruiting school staff to be trained. Almost everybody knows somebody with diabetes, and I'm always surprised about, how many teachers actually have a family member with diabetes, and they're already well equipped and willing to provide that care to a student.
Thank you. Should
Welcome.
school nurses have access to the password for a student's cell phone that is connected to the sensor in the event of an emergency?
I think, that's not enough information. Is the school nurse remote monitoring? I mean, I think that's a legal question too. Um, and also you could do a blood glucose check, a finger stick, if there's a question. I doubt that the school nurse would be that able to get that password. That probably isn't going to happen, but I would check with your school district attorney. But a lot of the school nurses are doing remote monitoring with CGM, so that's really not an issue. I don't know what you all are doing in Delaware, but I can tell you it's a nationwide trend for the schools,
You
school
just like
nurses.
that.
All right. I no remote monitoring in PA. And okay, so I'm going to ask just the last two questions here about transportation. Who typically educates transportation staff? And the other one is school bus drivers are not school employees. They're all contracted. And she's been told that there's HIPAA concerns to share medical information. So parents should be also jointly responsible for talking to bus drivers. And your thoughts?
My thoughts are even contractual bus drivers are working, they're not employed by the school district, but um, there is still an obligation because transportation time is school time. And there is an obligation under federal law to make sure that child is safe. So normally it would be a school nurse, could be a diabetes educator working with a school nurse, but it is up to that school district to train that bus driver. It is the school district's responsibility always to train the school staff. It's not the parents. Now, the parent can provide input, they can attend the training because every child's diabetes is different, but it is the school's responsibility to provide that training to bus drivers, to school staff, to everybody.
Awesome. Well, thank you so much, Crystal. We really appreciate your time tonight. And
Well, thank you.
please stick around and hang out for the rest of the night and join us again tomorrow to watch.
Thank you. Have a good night, everybody. Take care.
Thank you. All right, so next up, we have Dr. Paul Enlow, and he is, let me just give you a brief intro, and then Dr. Paul, I'll let you take it over. But we're pleased to welcome Dr. Paul Enlow, a research scientist at Nemours Children's Hospital in the Center for Healthcare Delivery Science and a clinical psychologist in behavioral health. He's also an associate professor of pediatrics at Sidney Kimmel Medical College. Dr. Enlow's work focuses on improving care and in reducing disparities for youth with type 1 diabetes through research-backed, family-centered interventions. With funding from NIH, PCORI, and other national partners, alongside his research, he provides direct psychological care to children and adolescents with chronic medical conditions. So Dr. Enlow, thank you for joining us tonight, and we look forward to your presentation.
Awesome. Thank you all for having me tonight. And I'm going to go ahead.
Make sure you can share your screen.
Are you guys seeing that?
There it is. Yep, perfect.
Perfect. Awesome. Okay. All right. So hi, I'm Paul. I'm from Nemours Children's up in Wilmington, and I'm going to be talking today about assessing and addressing social determinants of health among youth with diabetes. I have no conflicts of interest to disclose. Maybe someday I will. I'll let you know when I get to that point. I think really just kind of three main objectives for today. One, just to describe the prevalence and potential causes of disparities in healthcare delivery and health outcomes. And I'll talk a little bit about kind of like how I got to be interested in this topic, both in my research and my clinical care. Then I'm going to talk a little bit about some ways that we can assess social determinants of health. And then, of course, I think what's most important is what can we do once we actually find that families are experiencing SDOH. So I'm going to start tonight by just giving an overview of pediatric health disparities and social determinants of health and how those two things relate to one another. So before we talk about health disparities in diabetes, I think it's important to just talk about the United States as a whole. So the United States is becoming more and more racially and ethnically diverse. So the graph to the right shows the racial ethnic breakdown of the United States in 2010 to 2022. And we see that more and more racial ethnic minorities are actually becoming representing the majority of the population in the United States, with our Latino and Hispanic population actually growing the fastest. And so I think it was in 2022 where racial and ethnic minorities actually represented the majority of the population in nearly half of major cities in the United States, like Philadelphia, Boston, New York City, all of that. We're also seeing consistent growth in income inequality. So there's a lot of stats from the Pew Research Center, kind of on the right, showing that where kind of wealth in the United States is growing is among the highest, the top earner, the top 1%, top 5%, whereas we're seeing very relatively less growth among the middle class and lower class. So we're seeing more and more income inequality. It's becoming an issue. Some of us on this call might be experiencing. I know families are experiencing it as well. So more families are experiencing this economic instability. And this is important because these two factors, right, are racial and ethnic breakdowns and also economic breakdowns are going to come into play when we talk and we think a little bit about health disparities. So when I was in grad school, I took classes that talked about health disparities and talked a lot about, Black and Hispanic families have worse outcomes on this, that, or the other. But they didn't really talk about what was leading to these disparities other than the fact that they existed. As a psychologist, we focused a lot on things like mental health care access, rates of depression, rates of suicide, and things like that. But once I got into my postdoc and then as an early career, I got more interested in learning about health disparities more broadly, and we find them everywhere. If there's a area of work, a disease population, a specific treatment that you're interested in, chances are you can find health disparities in them. This paper by Flores and colleagues is a really, really good paper to read if you're interested in it. It gives a technical report on racial and ethnic disparities in the health and healthcare of children, and they find it everywhere, all the way, whether it's all-cause mortality, injuries, prevalence of chronic disease, access and quality of healthcare, mental health care, special healthcare needs, organ transplantation, you name it, they're finding racial ethnic disparities there. It also has like a really interesting kind of introduction where it talks about differences in racial and ethnic, differences in health and race by race and ethnicity, actually dating to like colonial times. There's papers written in like the 1800s that actually document this in a very different way than we would talk about it now, but it's not a new issue. It's always been an issue here in the United States. So in full disclosure, I am all my work and most of my clinical care focuses on kids with type 1 diabetes. But I dipped my toe in kind of looking a little bit about type 2 diabetes, just given that we're talking to the Delaware Diabetes Coalition tonight. The next slide is going to talk a lot about disparities in type 1 care, but we see disparities in type 2 care as well. So we see rates of type 2 diabetes are disproportionately higher among youth from minoritized backgrounds. So youth who identify as Black, Latino, come from lower SES backgrounds, things like that. The graph to the right shows the prevalence in the number of cases per 1,000 of type 2 diabetes among different racial ethnic breakdowns. So you can see it's the lowest among non-Hispanic white, highest among non-Hispanic Black. But when you look at the racial ethnic breakdown in the United States, it's actually flipped. So, there are more white youth within the United States than there are Black youth, yet we see higher rates of type 2 among our Black youth compared to white. And Black and Latino youth are not only are more likely to have type 2, but they are more likely to have elevated glycemic levels and experience comorbidities and complications related to type 2 diabetes. Like I said, I'm kind of a type 2 or type 1 person. That's kind of where my research and clinical background comes from. I really like this graph from this paper by Kokoska and colleagues that was published in 2018, which shows gets at kind of disparities in type 1 diabetes care. So this looked at trajectories of A1C for people who were diagnosed for the first 10 years of their life, so over 120 months. And they characterized 3 different trajectories. We kind of have this like low plateau group, this kind of high A1C group. They're diagnosed with an A1C of around like 8%, but then they kind of just like hang out there. They go up a little bit, but it's not huge. But then you have this Black group that starts high and then goes even higher over time. And obviously, we're kind of mostly concerned about that group, right? So who is not only starting with a high A1C, but going up over time, because they're going to be the kids who are the sickest. They're going to be in the hospital. They're going to be at risk for complications and maybe even mortality earlier than the kids in the orange and the blue group. And we find that compared to white youth, Black youth were 8 times more likely to be in that high and increasing group, and Latino youth were 3 times more likely of being in that major increase group. So clearly, we're seeing disparities. Oh, and I guess I should say, when you look at just the prevalence of type 1 diabetes, it's 70% white, 15 to 20% Black, similar amounts Latino. So the fact that our Black and Latino youth are overrepresented in this high and increasing group really tells us a lot about the kind of quality of care that they're receiving. We see inequities in things like outcomes. So Black and Latino youth from lower socioeconomic backgrounds are more likely to have DKA, be in the hospital due to diabetes, or come to the ED. There's some emerging research to suggest they have worse mental health outcomes related to type 1 diabetes, like more diabetes distress. And they also have experienced more inequities in care delivery, so lower rates of pump and CGM use. And this is kind of where I got into things. So I started my residency in 2015. And I got into the diabetes clinic right around the time that CGM was becoming more prevalent among adolescents with type 1. And I thought CGM was amazing. I was like, this is so cool. Everyone should have one, right? But then I started paying attention to the patients who had CGM and the patients who didn't. And the patients that had CGM were often affluent, highly educated, highly motivated. The kids who were struggling a lot with their diabetes, often my low-income families, families who identify as Black, Latino, they were less likely to have CGM. So this is kind of where I started getting interested in this issue of there's clearly a gap in care. What might we be able to do about it? And so I thought, okay, we know that inequitable care causes health disparities. So if we can achieve equitable care, right, if we can give everyone a CGM, everyone an insulin pump, then these disparities will go away, right? And then ta-da, we solved it. I'm a genius. No one has thought about this before. But that doesn't happen. So actually, even when you provide equitable care, you still see disparities persist in things like A1C and other health outcomes. There's this really, really great study that was done called the 4T study, Teamwork Targets Technology and Tight Control. It was a pilot, and they've kind of gone beyond that, where they looked at kind of give everyone a CGM, give everyone a lot of counseling and a lot of support soon after diagnosis, and let's try and close this gap. Let's try and eliminate the disparity. And so it was cool, right? They look at A1C over time. So each one of those little circles is a person, right? That's their A1C measurement over time. And those lines are those solid lines are the averages. The dashed lines are historical controls, but we're not going to pay attention to that. Well, what they found is by like 3-4 months, everyone's the same, right? Which is great. So 3 or 4 months post-diagnosis, we've achieved equity in health outcomes, which is what we were shooting for. But then a year later, or by 12 months, all of a sudden these disparities reemerge. So even though we're providing the same care to different people of different racial ethnic backgrounds, we still don't see reductions in the disparities. So clearly there's something else going on, and we need to try and pay attention to that and try and figure out what we can do about it. There's some observational studies, so not clinical trials, but some observational studies that kind of have suggested the same thing, but didn't have the strong evidence that kind of was needed to say, hey, this is bigger than just the care we provide. So if we put it all together, we know that youth who identify as Black, Latino, multiracial, et cetera, are representing more and more and more of the population in the United States. We know that economic instability is affecting more and more families within the United States. And these same youth not only received lower quality health care, but they've experienced worse health outcomes for decades. This is type 1 diabetes, type 2 diabetes, whatever it is. So pretty much more and more of our patients or our students um, are going to be shouldering the burdens of these disparities if we don't do anything about it. So eliminating health disparities is not just a kind of moral imperative, it is a public health goal. If we want to achieve a healthier country, we need to understand and try and address these issues. And the data, if we just focus on pediatric type 1 diabetes, suggests that disparities persist even when healthcare delivery is more equitable. So we need to just go beyond the care we deliver. I was gonna try and do a poll activity, but I was testing it out and it wasn't working. So I couldn't read my slides quickly enough. But I would just like take a minute, think a little bit about like what are the things that you see getting in the way of the your families or your students receiving kind of the optimal or recommended care. You can feel free to like drop it in chat if you want, or just kind of like think about it kind of like your phone. Language barriers, transportation, scheduling conflicts. Yeah. Oop, don't you? I know I had a patient today who came up and the mother was super engaged. Kid's having a lot of behavioral issues, wants to address it. Being unable to take work off appointments, childcare, insurance. Yeah, the mother I was going to say, she came in with her kid who's having all these issues, but two other kids as well because she couldn't get childcare. So we're trying to talk about her kid who's having these problems while also, entertaining the other kids as well. So it's a lot: work, schedule, housing issues, support and understanding at home. Yeah, all these things. All right, for the sake of time, I'm going to move on, but I like all of these ideas. Um, so in 2021, this paper was published that looked at what are the things that are leading to diabetes outcomes. So we're often focused on A1C, DKA, hypos, microvascular complications, all of that stuff. And a lot of the research focuses on diabetes care, right? It focuses on the technology. How can we get you into clinic? How can we make sure you're eating right and staying physically active? Give you tools to help you monitor your blood glucose, right? That's where a lot of the money is. That's where a lot of the things are. That's where a lot of the work is kind of focused on. And that pale yellow individual factors, we start to see a little bit of more work done there. So as a psychologist, we spend a lot of time looking at family relationships, how they predict things like, families who work together better tend to do a better job at managing diabetes, right? So one of the biggest things we do is we try and help families understand causes of family conflict and address it in healthier ways. But there's actually not a lot of funding out for psychological research like that, unfortunately. And even when we do that, the people who respond to those interventions tend to also be the same people who do well with managing their diabetes and achieving kind of those good health outcomes we want. And so Lippman and Hawks made the point that all of our research is really focused on diabetes care and individual factors. Very little is focused on social determinants of health, which is like economic instability, the neighborhood where kids live, the education they're receiving or the places where they're receiving education, the community context. And almost nothing focuses on societal or public policy issues. However, all of those circles kind of down the line, like diabetes care and individual factors, are going to be addressed by everything upstream. So we can work as hard as we can. We can create like the fanciest, slickest glucose monitoring technologies or insulin pumps, but those other things still exist and are still going to have effects on glycemic levels, complications, all those other outcomes. I have mixed feelings about Healthy People 2030 at the moment, but this is kind of what they say, right? So the federal government does still say that they're very interested in addressing social determinants of health. And they define social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, et cetera, et cetera, et cetera. It's kind of like where you are, what all these things. And they break social determinants of health down into those 5 kind of pie slices, I guess, in the figure to the right. So healthcare access and quality, the neighborhood, social and community context, economic stability, education access, and quality. I think it's easier to think about. I'm like a metaphor person. Maybe that's because I'm a psychologist, and that's how we kind of think about the world. Um, but the way I talk to patients or trainees about social determinants of health is to think of life. Life is not a river, or sorry, life is not a highway. It's a river. I ruined my own joke. Um, and we're all kind of navigating the same river. So we all have to deal with the same waves, the same rapids, the barriers, and all that. Most of us are getting through life in a canoe. Some of our canoes look fancier than others, some of ours don't. But some people are trying to navigate this river and they've lost their paddle, right? Maybe that means they've lost their job. They have a big illness in the family and they're trying to kind of get back on track. There are some people who are navigating this river in a super yacht where they don't actually have to do anything. They could just sip champagne while someone else drives the boat for them. And so those rivers and rapids are not nearly as impactful to them. And some of our families, and you probably have a person you can think of right now, don't have a canoe. They are in the water and they're just trying to keep their head above water. And now that's social determinants of health. It is not the challenges we are experiencing. It is the things that make it easier or harder for us to navigate these challenges. I always think type 1 diabetes is type 1 diabetes. You have to do the same things no matter what. But your ability to actually execute them can depend based on can vary depending on your context. This is a quote. One of my very first research studies I ever did is I was interviewing families of color and asking them about their experiences with accessing and using diabetes technology because I wanted to understand that gap. And his dad said this, and I still think about it to this day, and I use it as an example all the time. He was talking about his kid's Dexcom receiver failing or sensor failing. And he said, by itself, calling Dexcom to get a replacement sensor, that's not hard, right? I know the number. I can call someone on the phone. That's easy. But it is hard when you're working 2 jobs. You have to get your kids to practice, but the car isn't working, and you need to find childcare for your other kids. So all the things that you guys mentioned, right? Calling Dexcom is not hard. Doing it when all these other things are going on in your life is really, really difficult. I'm not a genius. I didn't think about any of this. Other people have been doing this work well before me. Felicia Hill-Briggs is amazing. If you haven't read some of her work, she's phenomenal. And she focused a lot on SDOH in relation to diabetes, and the health disparities in diabetes. So if you're interested in this, I'd recommend kind of looking at some of her work. She's really, she's amazing. So, she kind of characterized in this scientific review the different social determinants of health we see affecting diabetes care and outcomes. So it's socioeconomic status, things like education and job security, it's the physical environment. One of the big things I think a lot about is like green spaces, right? So if I work with a kid who's living in Hockessin, has a big yard, can walk around their neighborhood without worry of something dangerous happening, that's great. I work with other kids where the parents don't want them going outside because it's not safe, right? There's people who are dangerous outside. There's people who are not obeying stop signs and blowing through them. So yeah, their kid needs physical activity, needs to exercise, but it's hard for them to do that because they can't just go outside and do it. Food environment, so things like food deserts that make it hard for them to access good, healthy foods. Healthcare stuff, you guys mentioned insurance as a barrier, the social context. This is that social support. I saw some people bringing that up, right? Like support and understanding at home, having people you can lean on. I'm very fortunate. I have a 15-month-old son. My father lives 30 minutes down the road. He's retired and he can come watch my kid if I need to, right? My kid's sick. I don't necessarily have to call out of work because my dad can come over and grandpa can be on babysitting duty. Not everyone has that ability, and I'm very fortunate and privileged to have that. So we know that disparities abound in pediatric healthcare, including diabetes, other endocrine disorders, other physical chronic illnesses, you name it, they're there. Social determinants of health are the things outside of the clinic that are going to affect our patients' health and well-being. social determinants of health contribute to health disparities and therefore represent an opportunity for intervention. So when kind of trying to bring it full circle, when I got really hyped about, oh, if we can just get everyone a CGM, then we'll eliminate health disparities. The reason that it doesn't pan out is because the people who are experiencing difficulties with like their insurance, lost their job, things like that, that makes it harder for them to manage their diabetes, regardless of if you have a CGM or not. So yes, we need to get people these cutting edge technologies, but we also need to make sure that we're supporting families and getting through all of the, whatever they need to do to take care of their kid. I mentioned that kid who I saw in clinic recently, where the mom comes in with their kid and the two siblings. And I think a lot about that because, this mom's motivated. She's there. She drove over an hour to come in for her appointment. She wants her kid to get the care that he needs. But I also worry, how is she going to be able to actually follow through on some of the things we talked about? Not because she's not motivated, but because she has all these other things going on in her life too. And so that's the kind of that issue that SDOH represent. It's not how motivated someone is, it's all the things kind of around it. The good news is there are people doing a lot of work to understand how can we assess social determinants of health and how can we try and address them. Again, I'm sorry, my poll everywhere is not working. But I'm curious, how have you seen social determinants come up when you're meeting with a patient? I mentioned my example where the mom comes, she brings the patient who I'm supposed to be seeing, but the two siblings as well. So it's clear to me that there is a child care issue for this family that we actually need to think about in our treatment plan. So I'm curious if have you seen things come up in your own students, your own patients? You can just drop things in chat. Mhm. Having to meet the parent at work to get supplies, access to a car, lack of transportation, access to supplies, scarcer healthcare downstate. Yep. Medications costing too much, and so they run into gaps. Yeah. The QR code isn't working. I'm sorry. I couldn't get it to work. That's a me problem, not a you. Lack of ability to pay for meds. Yeah. Medication cost. I also think sometimes about like health literacy, right? Or tech literacy for I work with some of my patients, the grandparents are their primary caregiver, and they're maybe not as savvy with a phone. And so maybe they don't know how to follow their kid, right, on the CGM. And so we kind of spend a lot of time helping families work through that. Stable home environments, access to healthy foods. Stable home environment's a huge one, right? If you're with mom one week, dad another week, grandma another week, you have to make sure all those people know how to manage diabetes. So I see we're not alone. We kind of all see it. Mm-hmm. Yep. Two parents are involved, but only one can be involved. Yeah. So the good news is that assessing for SDOH is not rocket science. We can give people surveys, we can ask questions, and we actually probably want to do both. Parent who thinks the kid should be independent by now, that's like my bread and butter. Or the kids who don't want to be independent, but they should be. So I see it both ways. But yeah, that's like our most common referral is, some family issue and parents and kids are disagreeing about stuff. Mm-hmm. I didn't get on like to like shift work and stuff like that. But that's like a whole other thing too, right? Because then like if the parents are working like second or third shift, when the kids get home, they can be like unsupervised. Even if they legally it's fine for them to be home by themselves, that still raises another issue when it comes to type 1, like diabetes management. Um, But yeah, so like assessing SDOH is not rocket science. Questionnaires are really helpful. Asking questions are really helpful. You can do either or, and we'll talk a little bit about that in the coming slides. Or you can do both, and like kind of a combined approach actually tends to be most effective. Um, so, I think one of the things I always like to talk about or to consider whenever we're implementing something new, whether it's assessing SDOH, when we start like new mental health clinics, this is something we think a lot about too, is like if it's one psychologist and they're can only commit to being there 1 day a week, we have to think of like, can we do low level tasks? Maybe it's just or seeing patients who have screened high in a survey. Is that mid level tasks? Or maybe we're seeing every patient for initial consult for not follow up, or can we do high level intervention, which is, we can see every single person not only for initial consult, but for long term follow up. And when we're assessing SDOH, we can do the same thing, right? A very low level thing would just be to ask during the visit, like, hey, like, tell me other thing, are you worried about things at home, like access to safe foods? Are you able to afford medications, things like that? And I apologize, we talk about like EHR, so I'm clearly like hospital based and thinking that way. But a survey that's automated can be really easy. A high level intervention would be something like a survey plus like a social worker or someone who can do a lot more. But whenever we're thinking of what we might want to implement, we want to ask these questions of what are we currently doing, right? You don't want to duplicate processes, or maybe you want to take a process that's working well and build upon it. And then what resources are at our disposal? And I think that's usually the hardest one because SDOH stuff is usually asking for more resources, and it can be very hard it can be very hard at our hospital to ask for resources, so I can only imagine what it's like at a school asking for more resources. I'm sure it's challenging. At Nemours, we use an SDOH screening tool. It's very, very popular to use them because they are a low effort intervention. All you have to do is have a survey. You just send it out, people fill it out. We do ours once a year. Although we have been in one of my clinical trials, actually been administering it multiple times, which has been interesting because we see that some problems go away and some problems stay the same. So clearly we're able to help in some ways, but not others. There is no gold standard like SDOH screening tool. There's lots of different things you can do. CMS has a tool that you can use. I know Sarah's going to send up a slide, so you can click that link, or you can just Google health-related social needs screening tool, CMS, and this will pop up. This is what it looks like. It's 10 questions. It tells you how to score it. You can develop like automated scoring stuff, so you can ChatGPT actually probably help you like create an Excel spreadsheet that'll just score it for you right away, which is pretty easy. But it asks things about your family's living situation, food, transportation, utilities, safety, and all of that good stuff. And this one kind of shows also that a score, depending on how people respond to questions 7 through 10, that creates like a safety concern. I think it's just important to be mindful of that because if patients screen positive on that, then we should have a response. We run into this issue all the time when physicians want to start up a new mental health clinic or a mental health process. So they administer like the PHQ-9 to screen for depression, which has a suicide question. And so then they get all these kids screening suicidal who need to be screened that day, and then they're calling us up like, come see my patients. So just something to keep in mind if you choose to use that. Do you have the ability to respond to a safety issue? If you don't, you can omit those questions. And then it doesn't mean the problem doesn't exist, but at least means that you don't have to do something right then and there. The American Academy of Family Physicians has a form. They have both the short and a long form screening tool. This is the short form. And you can actually just ask these questions to people. So I like this one because it's almost like an interview format and sets you up to ask more questions. The last thing I like too is question number 11 is assistance. So you want to be asking this to kids, but maybe you'd be asking it to parents, which is if they have these issues, do they want help with it? And we actually get a number of people who say like, yeah, I have housing problems and no, I don't want help. And I'll talk more about that, I think, on the next slide. And then here's the Nemours version. You can see it's all the same issues, just kind of worded different ways. The nice thing is you can administer these electronically, you can administer them paper. They're all getting at like the similar domains. They have similar questions. So, if you pick one, you're not really losing out on that much. It's mainly just whichever one feels best to you. I really like this quote. It was from the paper from the American Academy of Family Physicians on their SDOH screening measure, where they say, social determinants of health are interrelated. So a positive screen on one indicates the need for an in-depth conversation about needs and challenges outside of like one specific area. So pretty much it's just trying to let us know and think a little bit about the fact that if a family's or says that they're having an issue in one area, we should talk to them more because chances are there's other things going on. Maybe they don't identify it as a need, but chances are they're still having issues. So if you have a family who comes in and is having difficulty affording medicine, they may also be having difficulty affording food or affording rent. And these are things that we need to be thinking a little bit about too. This is where clinical interviews come in, and they're kind of nice. So this is when you're obviously just talking with the person and asking a little bit more about it. So I always recommend within our own studies and clinics, we recommend starting with the questionnaire and then following up with an interview. The nice thing is that these questions can be asked by anybody who's trained. You don't need a degree, you don't need anything special. You can ask questions. You can actually just read off the surveys to people. And that's really helpful if you have families who might have low literacy levels or limited English proficiency. We use our screeners to inform interviews. So people might be asking follow-up questions about a specific area like food or housing or whatever. It's also important to remember, though, that people may be less likely to disclose sensitive issues like interpersonal violence during interviews. So if you're talking with someone one-on-one, they might be more likely to talk about like food insecurity, right? Everyone's talking about grocery prices going up. That's in the news all the time. That's not an awkward thing to talk about. It is awkward to talk about that, like, hey, I don't know if I feel safe at home because my partner drinks a lot and becomes violent. That's different. So questionnaires can actually be better at getting positives on those sensitive issues. Interviews can be better at asking more in-depth questions or getting at those kind of low stigma, kind of low stress issues. It's one of the reasons we like actually administering like the depression screeners that do have suicide items in our clinics, because kids are more likely to say yes to that than if I just barge into a room and ask them if they were having thoughts about hurting themselves. They're probably going to say no, but they might be more likely to say yes on a survey. So I think the big elephant in the room is like, okay, well, like, does anyone actually want to do these screenings? And it's mixed. I'm not going to like sugarcoat it. Families are concerned about it's uncomfortable to answer these questions. I was talking to a parent when we were going to include one of these surveys in one of our research studies, and she said, it is embarrassing as a parent to admit to someone that you can't put food on the table for your kids. And it makes me feel like a bad parent when I say yes to that. And so even if I am having that problem, I may not say yes. So I think that's just something to be aware of. Confidentiality is a big thing too, right? They're concerned about who's going to know about this, right? Is it just the school nurse who's going to know about it, or is like all the teachers going to know? I don't know if I want my child's teacher to know I'm having this issue. For us, the question is like, okay, why do I need to? I'm here because we're having conflicts about managing diabetes. Why do I need to answer questions about like whether I can afford my rent? That question could also come up in the context of school, and I think that's valid, right? So we have to kind of make the case that this is important for us when we're providing care. There's a huge fear of CPS involvement, right? If I say, no, I can't feed my kids, are you going to report me to Child Protective Services, and am I going to lose my kids? The answer is like, no, not necessarily, right? Like the not being able to feed your kid is not neglect and necessarily. Now, if you're doing it purposefully, that's a different story. And there's a lot of distrust and can be fear of discrimination. that families who are more likely to experience these issues are also probably may have had CPS involvement in the past and been reported on. And so there's good reason that they're reluctant to talk about this. When we talk to providers, right, so like medical providers, nurses, mental health providers, whatever, there's a lot of discomfort with asking these questions. There are time constraints, right? If you're busy and you're trying to see, like 30 different kids at once, talking to someone about these issues, it takes time, right? You need to be able to have some dedicated time to talk about this. A lot of people don't feel confident in their ability to address positive screen. So if something does come up, can I actually do anything about it? Or am I just going to feel like I made someone admit something that makes them feel bad and then I can't do anything about it? And the last one that I find I still struggle with this is, okay, someone has a problem, they disclose it, then I send it out into I tell them to go get some resources. Do I actually even know if they have access to these resources? And I think that's a huge problem. I don't have a good solution, and I'm sorry to say that, but it's like a real thing. So if you're feeling that way, just know that you're not alone. So this is that example I already kind of brought up. So talking about SDOH as an issue of trust, this parent said they themselves had experienced social determinants of health in the past, but they didn't want to admit any of it, right? So because their whole thing is, I've already asked for help with these issues, but I didn't feel like people followed through. So I'm only going to say I'm having problems if I trust that you'll help. So one thing is, if someone discloses this to you, that's a sign that they trust you. They really believe that you would be someone who would help them or at least take them seriously. So that speaks a lot to you as a provider. And if they don't feel like they don't feel comfortable bringing it up just yet, don't feel bad because it's a huge issue, right? You have to be comfortable being very vulnerable to talk about some of these things. This is just, I don't know if you guys will find it interesting, but when we are screening SDOH in our clinical trial, it's a peer mentoring intervention. We administer SDOH as part of our baseline. If there are needs identified, they get follow-up based on kind of the experimental condition they're assigned to. If they don't have any needs, it happens. But this is, 40% of our families had at least one SDOH need. Food insecurity would be the highest, but also difficulty affording healthcare, can't pay my bills, families who had housing issues, transportation barriers, and neighborhood safety. The nice thing is that families haven't objected to this screening as an interview, so or the follow-up, like when we sent them resources. So families seem to be okay with it. So if it's something that you're interested in doing, just know that it could work out. I'm a data guy. I don't know. But one of the things I found really interesting is we looked at the people who did and didn't have SDOH needs identified, and we saw that people without SDOH without SDOH had more insulin pump use and lower A1C and better time in range compared to people who did endorse SDOH. So this is kind of getting back to that, like, okay, how do SDOH relate to health disparities? Voila, here we see it, right? We see there's evidence to suggest that they are correlated. Okay, so we've assessed them. Now let's do something about it. Remember, think back to that low, mid, high, like what can I do based on where I'm at, what we're already doing, and what resources are at my disposal. So one thing to keep in mind is that the ideal intervention is what we call an upstream intervention. So this is intervening before SDOH needs arise. This is community level interventions. This is, for lack of a better, I don't have a better way to say it, but it's kind of like beyond a lot of us, right? It's like governmental things, it's societal change, things like that. It's super important, but one person's not going to be able to do it. So we want to focus more on like the current SDOH needs and downstream stuff. So this is catching families who have needs, but maybe they're still helping their kid manage their diabetes, right? This is maybe a parent who just lost their job, but are still able to afford medication due to they have some savings or severance or who knows what, right? Downstream interventions are, of course, more like, we have a positive SDOH screen and we're seeing, elevated A1Cs, DKA, all of that stuff. And this is when we're trying to get them to like resources and a social worker. But it'd be nice if we could move those referral to resources and social worker up further to the current SDOH needs. I could talk a lot more about this, but the take-home point from the scoping review by Yale was we need more upstream interventions. Most things are downstream, and most of them are screen and refer, which is fine. I think it's what a lot of us have the capacity to do. Upstream interventions are great, but they're hard because they take a lot of money, and they're hard to evaluate too. So if you guys are interested in this, I'm happy to talk more. I think the big thing is like, while we might not be able to develop and implement an upstream intervention, we should continue to talk about it. Because the more we talk about it, the more people will hear it and things might change. One thing I've learned in doing a lot of this work is if you're being a good advocate for these issues, you're often going to feel alone and uncomfortable. You're going to feel like that annoying person in the room. And that's not necessarily bad. These are hard issues to address. They make people feel uncomfortable. And so sometimes that gets turned back on you. So just know if you're fighting the good fight, it's okay to feel a little bit out of place. Okay, let's talk about downstream interventions because those are kind of more within most of our reach. So we want to think about community resources and then closing the loop. Their personalized list, the nice thing is a personalized list of resources there's evidence to suggest that it is just as effective as a resource list plus one-to-one help, which is like someone calling the family and coaching them through every step. So even if all you do is just send them some resources that you think might be helpful to get them over this next hurdle, that's enough. And that can actually make a really big difference. You can go to all of these websites, right? Are places where you can find resources. AuntBertha.com is a really nice one. I didn't know about this until I started working with one of our social workers. 211 helpline. You can get a patient action plan where it talks about, I think I show this on the next slide. So I'll wait a second. I don't, my bad. It's pretty much like you lay out kind of what the challenge the family is experiencing and what the next steps are. CDC has stuff, DHHS has community guides, communitytoolbox.org is a really great one, all that stuff. And the last one is just closing the loop, right? So this is what usually happens. A need is identified. So there's a need is identified, we refer out. Well, we don't know what happens after that. What we really want to do is there's a need, we identify it, we refer, and then someone follows up, right? To figure out a month or two later, hey, were you able to access resources? Was there anything else that you need from us, et cetera, et cetera. It's important because accessing resources isn't easy, availability changes, it's burdensome. Closed loop communication can help us understand success rates and barriers and can help us understand what we can do to help things going forward. Within the hospital system, there's increased emphasis on value-based care, which is like improving health, not just making money. And payers are kind of requiring evidence to say like, hey, if you do something and you provide resources, do people actually take advantage of them? So I always like to just like throw this out as food for thought at the end of the presentations like this, because it feels kind of overwhelming, like how are we going to change the world and all of that. But most of us, there's something, like one thing that we could do in the next 2 to 3 months to start assessing or addressing SDOH. It may be, hey, I know some patients who have been dealing with these issues, but I don't know if I've brought it up with, families yet, and this is something I want to do. Or maybe it's adding in an SDOH screener as part of kind of, I don't know, as a hospital-based provider, I think with like a new intake appointment, we're going to add it, but maybe there would be other ways to do that. Maybe there's a school resource officer or something like that might be able to help out with that. All that good stuff. Okay, so in sum, disparities are everywhere. SDOH are a factor outside of clinical care that affect our patients' health and well-being. And so if we want to achieve equitable care and reduce disparities, then we want to try and address SDOH. Addressing SDOH is important. There's no gold standard. While upstream interventions are great, downstream interventions are more realistic for most of us, and that's okay. We all need to start somewhere. this is the checklist I developed, right? So if we're going to start talking about SDOH or start an SDOH initiative, one thing that we can do really easily is just talking about disparities in SDOH in our meetings, right? We all have staff meetings of some way, shape, or form. Bring it up, right? This is when you can be that advocate. You might kind of seem like the bummer, right? Where we talk about issues that are hard to address, but it's important. We might want to measure equity in some way. We might want to screen SDOH and then maybe have quality improvement initiatives focus on one of these things. An example from a Nemours institution, Nemours, we noticed that patients were having difficulties with insurance covering CGM. So it was like back in like 2019 or 2020. Insurance required documented nocturnal hypoglycemia for them to have CGM. So what we had some free samples of freestyle, and then we leveraged that to get Dexcom to give us free stuff. And we started patients on CGM while they were in the hospital. Anyone who's newly diagnosed with type 1 is going to have hypos because they're honeymooning, right? And so then we use that CGM data to go back to the insurance company and say, look, they had a nocturnal hypoglycemic event, cover their CGM, and boom, that worked. So we started all of a sudden seeing a huge increase in insurance coverage for CGM, and it really eliminated a lot of that disparity. And thank you for listening. There's my son, so you'll ask the next questions.
Awesome. Thank you so much, Dr. Enlow. We appreciate it. So just a real quick programming note, if you notice your inbox, I just automatically sent the follow-up survey through the email. I'll also put it in the chat. But before we get there, a few questions for you. So access to care, I think this was to your comments where you were asking for feedback, but just some so you can hear what they said. Access to care in the rural areas of Kent and Sussex County is one huge problem we have down here. And Dr. Enlow, I find at my school it's a transportation and guardian education. The Delaware Division of the Visually Impaired has started delivering the students' glasses to me at the school. If diabetic supplies were delivered to the schools for transport, my pre-K to 1 diabetics may be better served. Just a thought.
Yeah, no, and I think like things like that are really good ideas, right? Because you're thinking of like a systems issue, and kind of how we might be able to address it. So I love that.
Yeah, that was a good idea. As students with diabetes approach 18 years old, is there a program to help them transition to adulting with diabetes independent of their parent and guardian, which
Yeah,
we are going to hear tomorrow from Blue Circle Health, but
yeah,
go
yeah,
ahead
yeah.
and answer that.
So yeah, Blue Circle Health obviously has that, and things like that. A lot at Nemours. So if they're seen at Nemours, we do have a transition clinic. I will say kids often get referred to the transition clinic late. So ideally, we want kids referred to transition clinic when they're getting close to like 15 or 16, because it starts it starts that conversation before kids turn 18. And the conversation is often focused on like, what does your kid understand about managing their own like condition? Can they schedule an appointment, right? We've all like worked through phone trees to get to like where we need to be. That's a skill that you have to develop. And so it's things like that. It's like insurance coverage, right? Like understanding what's your copay versus your deductible versus your co-insurance versus your right? So like they do things like that. So if they're at Nemours, you can encourage the parents when they hit like around the time they start driving, they should also schedule an appointment with uh, transition clinic. And then if they're not at Nemours, they might have things elsewhere.
Awesome. Thank you. So, some Delaware schools provide free breakfast and lunch. There's also the backpack program, which sends food home on the weekends through the food bank. So food insecurity can still be an issue, and managing carb counting can be an issue. If there's a registered dietitian available, they may be able to help.
Yeah.
Comment. Do you have resources for school counselors helping students who experience mental health issues regarding medical conditions? Something as a school nurse I could use or pass along.
Yeah, I do, like not right on hand, but if you, I'm just gonna drop my email in chat. Um, so if you email me, there's lots of different things, and so it could be diabetes related or other things as well. So yeah, just shoot me an email, and I'm happy to provide some resources.
Awesome. And the last one was about the presentations and the slides will be available. The slides are in the email that just went out, and they'll also be on our website. And I will have the recordings posted probably by next week. So with that, thank you so much for your time tonight, Dr. Enlow. We really appreciate it. And for everyone else that's still on, we will see you tomorrow night, same time and place and 6:30 to 8:30 tomorrow night, and we will hear from Blue Circle Health about type 1 into adulthood, and NASN, the National Association of School Nurses, are going to talk about their toolkit. So we look forward to seeing everybody tomorrow night. Thank you for dealing with me and my child, and we will see you tomorrow. Thank you.